All right, let's go. Oxygenation. Okay. I'm gonna skip all this anatomy and physiology. Y'all already know this stuff. You need to know it if you don't. Am I gonna ask you what's the function of the nose? No, y'all already know. But you do need to know that information to help you answer a lot of the questions, okay? Anatomy of the lungs, I'm skipping all of this. Know the components, what the function they serve. You need to know this, especially alveoli, surfactant. You cannot play with that information, that basic information when you're answering a lot of these respiratory questions, okay? Skipping all of this in the interest of time, make sure you know what respirations mean. All right, I need to get to the real good stuff.
The bueno stuff.
The bueno stuff.
Stuff that gives you that impresses.
Listen, the cardiac system and the basics related to the cardiac system. I know Sully has drilled this in your brain, in your membrane, your cells. You better not play with me, okay? Make sure you know what the SA node is for. What's the SA node again? I forgot.
Pacemaker.
Okay. All right, very good.
Ask him all the questions you want about the heart. He knows it.
Oh, you want to be careful? Okay, I got something for you. Maybe tomorrow, okay? You do need to know the factors that do affect the respiratory and the cardiac system, okay, or cardiopulmonary system. Don't play with me. The level of the health, like we just saw right now. If you have congestive heart failure, not only are you going to have cardiac issues, you're also going to have respiratory issues as well. So what's the condition or the level of the individual's well-being or health? Developmental considerations. Again, just like with any other body system, the younger you are, your system is going to function differently than when you are of older age. For example, the new kids on the block, the neonates, their respiratory, or if you see if you go back to the vital signs chapter or the chapter that talks about vital signs, you'll notice their heart rate is much higher baseline than that of the adult. But when you get older, like a young adult or adult, the heart rate declines, okay? So in terms of the baseline. So pay attention to the developmental considerations. I already told y'all are legal drug dealers. Do not play with me. So, Sakina, what are some medications that affect cardiopulmonary system?
You have your beta agonist, beta 2 agonist.
Beta 2? I don't know what that is. Beta 2? Your big words. What the heck is that?
Okay, so you have certain drugs that's going to affect your respiratory system. Anything that will be like the pills. And then anything that's, you have adrenaline that will open it up if you need it.
Give me more.
Oh, yeah, what you said?
The laws.
The laws out
The
there.
laws. Okay, your metoprolol. So you got your blood pressure medication. You got your respiratory medication. Beta agonist. Okay. All of that. Besides your blood pressure medication and your respiratory medications like your albuterol and stuff like that, is there any other types of medication that have an impact on the cardiopulmonary system?
Natural.
You said blood thinners? Ooh, you're going to have to elaborate on that. I was not expecting that. I don't know about no blood. First of all, I don't even know what a blood thinner is. So you're going to have to explain that to me.
Antiplatelet medications, like sometimes you need them for if you're having issues with your valves, you're having issues with sometimes the patients have like blood clots, anything along those lines. You want to make sure that you can either break up the clot or you can make sure the clot does not move.
So how does those medication impact the cardiopulmonary system?
The pulmonary and the cardiac system are completely connected.
Okay.
It helps with the flow of your blood. So if your blood is too thick, your valves are going to work harder to try to push the blood through, as opposed to where if your blood is too thin, they won't be working as hard. So
what does those medication? How would you see those the effect of the medication displayed? What are the symptoms you would see cardiopulmonary wise, since he's going there? You open that can of worm, not me.
Or if like a patient is having any type of heart pain, if they're having issues breathing, shortness of breath.
And I give them an anticoagulant or an antiplatelet, what would I see then afterwards?
If you're giving a patient who's having chest pain, maybe like if they're having a heart attack, and usually an antiplatelet is one of the drugs that you would give them.
Okay, you are on the right track. They'll eventually be on that, depending on the diagnostic results, but really they'll be like on something like nitro for a heart attack.
Yeah.
Okay? And yes, that will have an impact on your blood pressure. That's why one of the things you want to do is assess the patient's blood pressure. All right, Trinity. Opioids? Queso. What is that?
Fentanyl.
What is that? What is opioid? Okay, Carlos, he wasted no time on that one. All right, what is that?
They slow your respiration.
Oh, I got a question for you. You open that can of worm, not me. Okay? So of course I'm gonna have a question for you. You said opioids is what kind of medication again? Generally speaking. Given for what? Pain meds. And you said it has an impact on what again? The respirations. How does it affect the respirations? It can slow the respiratory status down. Okay, since it can potentially slow the respiratory status down, like before administering these pain medication, patient's heart rate, respiratory rate was like maybe 20, and then after the opioids is now down to like 9. What we gonna do with that? Okay, before you call the physician, y'all quick to call these doctors. Y'all know these doctors gonna get tired of y'all, right? Y'all be calling them, hey, any little thing, doc. No! Before you call the doctor, what you gonna do?
Check the
Stop. Reminiscing, listen. Okay, no, anyway, but before you do that.
Try to get them to respond.
Okay, anything else? Before you call the doctor. Yes, you're on the right track. What is there anything else you can do? We talked about it
I don't know, elevate the bed.
already. Okay, yeah, you could do that. And patients on opioids. Trinity gave the pain medication like she's supposed to. Before she gave the pain medication, respiratory rate was 20. Normal. After she gave the pain medication, it dropped down to 9. She stimulated the patient. Patient's coming back up slowly. Is there anything else she could do?
Narcan.
Thank you. You have to have Narcan on hand. Because Trinity know what these pain meds can do. Always have backup. Okay?
It's Narcan not need to be prescribed, you can just administer it.
It's not that it's not prescribed. In most facilities, it's like a standing order.
Okay.
Okay? Or sometimes it's facility protocol. Okay? Sometimes in certain facilities, you may have to call a rapid response just to get the Narcan. It depends on the facility, for real. Okay? But before you call the physician, in some facilities, you may end up having to call the physician, but the patient might be
Already
yeah, okay? But yeah. So other medications that have an impact on the cardiopulmonary, you said what again? Diuretics. Okay, talk to me a little bit before I get to Mason.
Volume, and it causes less stress on your artery walls.
Okay, so if it can lower your blood volume, I like how you said that. Is there a negative impact that it can potentially cause these diuretics?
Also the electrolytes.
That's one. What else? So as a result, what would you see the vital signs? How can it affect it negatively? You're right. Diuretics do have an impact on the cardiopulmonary system.
Well, it's taking the salt and the fluids out of your body.
So how would you see the blood pressure? Would it go up or would it go down? Exactly. You see, and it might go 2 down.
Because you're losing fluid, you're excreting fluid.
Exactamundo. Okay, very good. Mason.
I was gonna say ACE inhibitors or ARBs.
ACE inhibitor. I don't know what these means. Y'all acronyms.
They're like angioconverting enzymes.
Angioconverting
They
enzymes.
block the,
Boy, Dr. Graham gonna love y'all next semester.
and they lower your blood pressure, so your ventricles and stuff don't have to work as hard.
So because these now what am I doing with as a great fantabulous nurse that you are, Mason? what are you going to do before you even give these ARBs or ACE and PRILs and laws and stuff? Huh?
Check their blood pressure.
When are you going to, now I'm going to ask you this. When will you check the blood pressure?
Before I administer it.
And?
After.
Thank you.
Because if it gets too low, they can bottom out.
Thank you very much. You said, okay, all right. Any other, okay, so we said pain medications, we said blood pressure medications, we said these pills, OLAs. Is there any other medications that can have an impact on the cardiopulmonary system? And it's listed in your book. Whether y'all tell me or tell them to me or not, it's gonna come on your test. Look, now somebody gonna open their book. I ain't gonna say who, because we live, but at least it's not on the floor. But you know.
Cholesterol ones, the ones that like lower
Is the
like LDLs and stuff to prevent like plaques to build up in your arteries.
And contraceptives as well, right, can increase the blood pressure.
I don't know. Cholesterol medications to have an impact on. You might be right. I don't know. Let's look it up. I don't know. You guessing? I don't want to give you no more misinformation. What does the book say, Cassandra? While Mason validate whether or not cholesterol medications have an impact on your blood
I'm trying
pressure.
to find the cholesterol, I just find the contraceptives.
What about the contraceptives?
They can increase the blood pressure.
The contraceptive medications can increase blood pressure, and because of the other impact that they have, this is one of the, since you mentioned contraceptive, you'll learn later, you want to make sure these patients who are clients who are taking contraceptive, they don't smoke because it can increase their risk of DVT. Okay? Yes.
It says drugs that like statins,
Statins.
they lower LDL cholesterol to prevent plaque buildup in arteries.
But what does it do to your blood pressure?
I don't know if they, I think it's really just to like so like your arteries don't get clogged and you don't get like peripheral artery disease and like adicoac.
I mean, I know, you know, the statins help.
Probably
Huh?
decreases.
It decreases your blood pressure?
Probably lower it.
Probably. Not you saying ask Google. Any other meds? While Mason is trying to validate what the blood cholesterol medications, these statins do to your blood pressure.
It says it lowers it, but it's like very modest.
Very. It doesn't do it too bad. It some people don't even touch it, you know, for some most. Any other meds? What else does the book mention? Hurry up, hurry up, because it's gonna come up. Yes, Sakina.
Theophylline,
Oh, theophylline. What is that?
a bronchodilator.
Oh, bronchodilator. I don't know what that means. What that mean?
To dilate your bronchioles in your lungs, therefore allowing for more oxygenation.
Okay, when you said dilate, because you know me don't speak English very well. Hold on. You talk too fast for me. What that mean, dilate?
It's gonna open up.
It's going to open up
your lung capacity.
my lung.
So you can breathe in more.
I'm going one question for you, ma'am. Doc, listen to me. Because, you know, I know people that take that thing you call the opener. Right? Open the lung opener. Let me ask you something, Doc. Let's say, because I saw this one time. Let's say the patient, the O2 sat, that's what you call the saturation thing, okay. It was like, one time it was like 88%.
That's very low.
It's very, I thought so too, you know? So I said to myself, oh my God, that patient in trouble. Right? But that patient, they say, got asthma. You know, that's very dangerous, you know? So I look, the nurse walking, though they checking, you know, they put machine on the patient finger, that, whatever. And then, but they said the patient have difficulty breathing, so they need the medicine. But you said they need the lung opener, right? But I noticed one thing the nurse do is put the oxygen, but the patient still in trouble. They, you know that cord they put, you know the cord they put in the face. I said, oh, why? Okay, that cord's supposed to give oxygen.
Yes.
But why is there no? On the contrary, the oxygen went down to 87. I really hungry. You know, I said, oh! I said, ah! So why? What happened?
Because that person has COPD, that's a problem, and that's their lungs capacity cannot have a whole bunch more oxygen in them.
Okay.
There's trapping in the lungs, so we don't want to overpower them with oxygen.
Okay. So what's the first thing that nurse supposed to do? Give the oxygen or do something else?
Yeah, I wouldn't give them oxygen.
The person that's COPD, the person have asthma.
That person has asthma.
Yeah.
So then you want to go ahead and give them an epinephrine, because right now
She changed it. You just talked about the bronchodilator.
Well, that's epinephrine will be also
Okay, well, yeah, that's
as
true.
well.
Okay.
And that will open up their lung capacity for them to even breathe.
What am I getting at? If the patient is asthmatic, O2 stat is low. What should you give first, oxygen or the bronchodilator? Why? To open up the lung. NCLEX love these type of questions, and so do I.
You can't get no oxygen.
Exactly. So it's a waste of time giving oxygen. Okay? So if the patient is asthmatic, for example, or emphysema, well, really asthma is the most common. The first thing you're going to do is give the bronchodilator, albuterol, something, whatever they have, epi, whatever, okay? Then you give oxygen. Y'all hear me? Yeah. Okay. Thank you, Doc. Any other medications that have an impact on the cardiopulmonary system? Hurry up because it's 10 o'clock.
Corticosteroid.
Oh! Oh, look at y'all. Great minds think alike. Both of y'all split it? Okay.
Say fools never differ.
Okay. I wasn't expecting that one. Listen, how does the corticosteroids have an impact on the cardiopulmonary system?
Hypertension.
Oh, it causes what? Hypertension. So what you doing before you give your corticosteroid?
Check blood pressure.
You better check the blood pressure before and after the C. Okay. Now, going back to medications such as albuterol, they also have an impact on the cardiac system too, or heart rate specifically. Sometimes it causes a heart rate to be elevated.
Yeah, that's the work harder.
Yes. Okay. So sometimes you might have to get either an adjustment or whatnot. Lifestyle. Quickly. If I'm just sitting on the couch watching Netflix all day. Sedentary. What does that do to the cardiopulmonary system?
No good.
Not good. My blood pressure most likely will be what? Well, initially high. Okay. Or if I'm eating, I may not be so sedentary. I may drive around to the drive-through fast food store. Mickey D's, Chipotle, whatever. All that sodium. Not good.
We love sodium.
Bro, don't do
Sure
that.
do.
Okay?
Sodium brings
It's
water.
good.
While I can understand lifestyle, meds, developmental, I don't understand how in the world does environment have an impact on my cardiopulmonary system.
Well, if you live somewhere and there's a lot of stuff in the air, that
Yeah,
can affect
Air
your
pollution.
Air pollution, very good. What else?
Where do you work?
Say it again.
You live with a smoker?
You live with a smoker. Okay, that's another. Okay, Rudy, you said where you work. Are you saying where I work right now can have an impact?
Well, yeah.
How?
Because you're more exposed to dangerous bacteria. Firefighters are more exposed to
Good one.
smoke inhalation.
Good.
Mine workers are more exposed to chemicals that they could be breathing in. Factory workers, et cetera, et cetera.
Etc. Or high stress environments too, especially when you're exposed to those high stress situations at a lengthy period for years in or out. That could also have an impact because your blood pressure could stay elevated and you might end up by being at risk for stroke. Huh?
These next 14 months.
Don't play with me. All right. And psychological. Tell me about psychological real quick. What does the book say?
Well, if you're stressed all the time,
Huh?
if you're stressed, you have anxiety.
Okay, what else? Is that all that the book mentioned?
If you're depressed or
Okay, talk to me about depression. How does it have an impact on cardiopulmonary?
well, it can cause if you're constantly depressed, you can I know that you can have ebbs and flows in in your heart rate, your anxiety gets heightened, so you have more panic attacks or stuff like that. Something like that. I'm
All
trying
right.
to find it in the book, but
Says you can exhibit hyperventilation, which
Yeah.
leads to a lowered level of arterial carbon dioxide.
Good. Okay. So, in other words, your psychological status, anxiety. Okay. We talked about the different levels of anxiety as well. If you're constantly anxious, of course, respiratory status is impacted, where you might be tachypneic for the most part, hypertensive too, etc. Okay. Very good. Moving forward. Now, that I told y'all I'm not gonna test y'all on the kids. Lucky y'all. So don't worry about it, because you're gonna get a third semester, some way, shape, or form. But let's move forward. The older adults, yes. This semester you will be tested on that. You need to know about the respiratory functioning, typically that you'll see in the older adults. One of the things is, especially because as we grow older, they have a tendency, depending on how bad it is, they might have kyphosis. What is kyphosis?
hunchback.
The humpback of Notre Dame, just thing like that. Now, if I'm constantly like this, not me, because I'm always be straight, but if the client is always like this, how does that affect your respiratory?
It restricts the amount of oxygen you can.
Okay. So in that turn, they're gonna have respiratory difficulty, distress, or respiratory distress. Very good. I never heard of this in my life, Carlos. What the heck is barrel chest?
Barrel chest is when when you look at them, their chest is a little bit more protruded than the rest of their body.
Mm-hmm.
So it inhibits the way they breathe.
You see it a lot in COPD. So it's all equal. You're gonna see. Look at y'all see a barrel. Everything is all equal. In other words, right? So it does impede respiratory functioning as well. They have decreased poor oxygen perfusion as a result of this barrel chest. So these patients, you are constantly monitoring their oxygen saturation too and respiratory rate as well. All right. Older adults, so you will see barrel chest in many older adults. You'll see it, like you mentioned, like in COPDers or those with chronic emphysema. That's all I got off the top of my head. Okay. All right. Older adults are at increased risk for diseases, especially pneumonia. And because of this is why you want to get these older adults moving as much as possible, because pneumonia, it loves when a person is sedentary or has limited movement. So this is why in many patients who are immobile or have limited movement, you want to make sure you turn them frequently, because if that collection of sputum or bacteria stays in one place in the body, there goes pneumonia developing. And then here you go having respiratory distress. And one way you can alleviate that or prevent that is getting the person moving, or at least turning them frequently if they are immobile. All right? Physical assessment, what are you looking at or what data you're going to be collecting? General, you always start off least invasive. That's why sometimes if you're just talking to the patient, you get into the room, look at them. Be all up in their business. Like, ooh, okay, I see you got your hair did. Mm-hmm. You know, okay. Baby hairs on T, okay. All right. Ears intact, okay, you smiling. And you make the patient laugh on purpose. When you make it, it's not just to make them feel good, but you're also assessing the client. You don't have to say, smile for me. Just make a joke. Smile. And I'm looking to see how you smiling. You understand? And when you are talking, as you are talking, the more I'm getting you to talk, my assessment is going to see, do you even have difficulty talking in the first place? You understand? You don't have to tell the patient, hey, talk. You know, but just get in the talk, have a conversation. How you feeling? What's going on? And I am assessing how it is that you are conversing with me. Do you have difficulty conversing with me or talking? Does that mean that's my respiratory assessment right there? Okay. Now I will tell you, once you enter the room, if the patient is quiet, still laying down or sleeping, that is the best time to do to assess their respiratory rate. Don't wake them up yet. You gotta be sneaky. No, yeah, you do have to a little bit. You're like, come in. Okay, let me see. Do I even see any chest rise and fall? That's the first thing I do. Look for when I go into a patient's room. Do I see any chest rise and fall? Or if they're laying on the side facing the window away from the door, okay, do I see any movement towards the back or something going on? That lets me know you're at least alive, okay? You're not in distress, all right? Then I'll go into the more invasive. So you always start with inspection. Your assessment, no matter what it is that you're assessing for, always start with inspecting, where you're just observing the client. Leave them alone for a little bit upon entering the room, or with your first encounter with the client. Leave them alone and expect those general appearances. All right. You're looking at the respiratory rate. You're looking at the depth of the respirations. Do they have any shortness of breath, for example? Look at their color. Is their color appropriate for their ethnic background? Okay, like I'm looking at Mason, okay, the haircut threw me off this morning, but he looks appropriate. He's not blue. He better not be. You understand? Now, you see how it says assess for cyanosis? There are some ethnic groups, it is difficult to just look at them and assess for cyanosis. Which group? Black people. Okay, but I gotta assess for cyanosis. I can't just say cyanosis absent.
Oh, you check the mucus membrane.
Thank you very much. Okay. Because it's coming to you.
Because I got it wrong last time.
You did? I asked that question already?
Yeah. No, it was on a different one.
Right?
Yeah.
Oh, I was gonna say.
I did. No, it was physical. Yeah, I don't know what class it was. I did
Okay.
I did the eye, and she was like, no. She was like, yes, you can, but
you can.
It was yellow. It was for jaundice. It wasn't for cyanosis, though.
Okay.
So because it was jaundice, I was like, oh, you would assess the sclera, but then she was like, for darker skin, you would do the oral mucosa always.
All right. What else? So look at the chest, palpate. How do I palpate your temperature?
Look.
I'm not gonna say who, TikTok. No. I'm not gonna say who. Somebody said I assess for temperature this way. I'm not gonna say who. Okay? Now look, she turned it red.
It's because you said palpate. Why you said palpate?
It's true. How do I assess for temperature?
No, you don't touch them for their temperature. You use the thermometer.
No. Okay. Yes. How do you palpate? Yes, you
bilaterally.
Can. Bilaterally.
Yeah. No. Can't you just use like the back of your hand?
What do you use? Let me say it this way. What do you use to palpate a
back of the hand.
Thank you. Yes. Okay.
You're talking about I thought you were talking about an extremity.
Wow.
But when you're checking the temperature, like for extremities, you would use both, like you would touch both, like for temperature, like if you have a hot leg versus like a normal temp leg.
You could do that.
Wouldn't you like hold both, like you would hold both to not hold both, but like feel both?
You don't want to use the palm of your hand.
No, I'm saying, but you would feel both at the same time.
Yes, you can do that. That is sure. But what am I getting at? Because if you don't read that question carefully, you're gonna get it wrong. You should not, in other words, be using the palm of your hand or your finger pads or your fingertip to palpate temperature. No, because it's coming from you. Yeah, okay. All right, read carefully. Okay. What else? Palpate temperature. Look out for chest expansion, tenderness, mass, pulsation, etc. Percussion of the lungs. Definitely you want to percuss the lungs. Now, I will be honest with you. You should know this mostly because health assessment is going to get you on this. I don't do this. I'm not going to test you too much on that. I don't think I have a test question on percussion, lung percussion. Yes.
With the auscultation, like we get a question, is it going to be like every single point, or is it just going to be like the top two or bottom two?
Or is it going to be about?
Because I was at clinical, and they said if it's not like their first time like being there, like they've been there for a couple of days, you just do like.
Oh no! So okay, in the real world, you do a baseline assessment, and sometimes, if the patient is stable, real talk, if the patient is stable, you don't have to keep doing it with every interaction. But if you do notice a change in the client, you need to do it again, even though you had the patient already.
Like the NCLEX, is it going to ask like you do every 5 points in the front and then
NCLEX, they might ask you all the points. Or they might even ask you to locate the, identify each landmark.
Are you gonna, like, it's like, are you gonna ask us? Is it gonna be like in the question, is it ask with is it gonna be like every point or just?
Yeah,
like,
I mean, you just gave me a nice idea.
Just add it on there.
Thank you.
The notes.
I mean, you just gave me a very nice idea. Cornelius, you had a
8 to
question?
men.
No, I was just gonna say, I had a patient this last week that had a hospital-acquired injury on his arm, where they pinched his arm between a gurney and a stretcher.
Oh, they heard him in the hospital?
Yeah, and they he had a big wound. But anyway, the nurse noticed that it was draining,
You're gonna have to
and when
erase
she took
it.
the bandage off, it was like all black, and it had been like, I mean, his
Trying
right arm was
your way,
twice the
I
size
don't
of his
like
left arm.
Oh, wow.
And so she immediately started like doing an assessment, like she assessed his respiratory and stuff, and so she was listening for like lung sounds and different things, because he had anxiety the entire morning and he couldn't pee and poop and whatnot, and so she started doing this before they called for an emergency, basically.
Of
taking
course.
him to the ER, so.
And his arm went black?
His arm, like in the wound, was, I thought it was necrotic, but she said it was eschar. But it was but I mean, it was probably a 4-inch, like, in diameter wound. And
So they weren't doing his wound care?
they were doing wound care, but the doctor prescribed wound care only every 3 days. And so she had changed it the shift before, and when she came in, she noticed that it was draining. So she said she's gonna change it. She asked the doctor if she could change it. He said, yeah, that's fine. We took it off, and it was black, like underneath. It was
Was he in
draining
pain?
blood. It was draining blood, basically. He had pain, but it was like to the point where like it wasn't as bad. But when I was doing my assessment with him earlier, I told the nurse, I said that his extremities were feeling really hot, because I was feeling his like legs, and they were like, I mean, I've never felt like skin that warm. It was insane. I mean, felt like the guy had been baking in the sun all day.
And he was inside all day?
It was in the morning. He had just woken up.
Their
interesting.
AC like broken or something too.
No, his room was like 75
Oh, their
degrees.
AC was broken?
No, it's just
his-
warm in there
his
in
room
the
was 75
rehab.
degrees, but
It's
he had like very warm extremities. He had pitting edema.
I had a
I mean, he
patient who
just,
had, like, really
the guy was really, and he was an infectious disease doctor.
Oh, damn.
But yeah, they transferred him. But anyway, that was, my point was to talk about that they did the quick assessment.
Just note that because of Mason people, yes, Mason gave me a very good idea. You do need to know your landmarks. Y'all already did it in not patho, health assessment. Let's go look for a question. Okay?
Yeah, everyone's not really doing that good in that class.
See? There you go. Physical assessment, page 783, the landmarks are there. Okay. Before I move forward, yes, you are going to be auscultating the breath sounds. I want you to know the different breath sounds on page 1599. You must know them. Y'all should have known them from health assessment anyway. On 1599, you should know, like the normal breath sounds, what does that mean? It's vesicular.
Oh yeah.
Low pitch sound. Then you have the bronchial. That's a loud, high pitched sound. Huh?
It just depends on where you
It's like where, yeah, because the vesicular is like your bronchial is like in the middle.
783.
Right. Oh, look at Mason. Mason. Okay. Alright, I like it. Okay, but yes, like it says, it's heard over the peripheral lung field, bronchial, high pitched sounds primarily heard over the trachea and the larynx, and then you have the bronchovesicular, which is medium pitched blowing sounds heard over the major bronchi. Okay. Also, the other sounds that you are listening for, adventitious. These are abnormal breath sounds. Okay. You got the crackles. We should not be hearing snack, crackle, pop. It should not be Rice Krispie treats in when you auscultate the lungs. Because if we do hear that, what could we suspect?
Pneumonia.
Huh?
Pneumonia.
Or what? You said what?
Heart failure.
Oh, okay, heart failure or fluid overload, etc. Okay. Atelectasis. Okay. Wheezing is another sound. Okay, very continuous. Most books identify like a musical sound. It's not limited to asthmatic patient. Yes,
So
Anton.
if you were doing an assessment in the or in your practice, and a patient comes in wheezing and you rule out it's not asthma, and you think it's like a tumor or something, how would you?
You ask the doctor, recommend either CAT scan, MRI.
But you don't assess for that.
No. The doctor has to do, because they will rule out, as nurses, we don't rule out any disease process. Remember that.
Yeah.
The physician is the one who's going to rule out whether the patient has asthma or not, or tumor or not. They ruled out asthma, okay, now we're gonna look at something else. What's your lung capacity looking like? So they'll do further diagnostic workup. You just do your assessment as necessary, and you can recommend that. It's okay to make recommendations. They'll just accept or refute it, all right? All right, you see the auscultation of the heart sounds? Make sure you listen for the lub-dub, and we're gonna talk about the different lub-dub. And hopefully tomorrow you should, lub-dub is what? S1, S2. That's what we love to hear. Lub-dub, lub-dub, S1, S2, S1, S2, S1, S2. That's what we love to hear. But there are some people, you might hear an extra heart sound. Is it always bad?
No.
When is it not bad?
Like older.
Older people, even the younger generations too, okay? Or pregnant women too, because they got an extra, body in them too. So we're looking at all of that to make sure why we're hearing an extra heart sound, okay? All right, what else? EKG. Tomorrow, if I don't have a chance today, we're gonna go into the different types of heart rhythms, okay? We'll talk about the PQRST. I know Dr. Sullivan already talked to y'all about that, right? The PQRST, she showed y'all the different rhythms.
Yeah.
So y'all know what NSR look like? Normal sinus rhythm. Y'all know what sinus Brady look like?
Yeah.
Y'all know what sinus tachy look like?
Yeah.
Y'all know what asystole look like?
Yes.
Look. As you feel like,
I was waiting for you to say AFib.
I won't do AFib, DFib, PEA, junctional, all that stuff. The extra, more intense ones, you're gonna get that next semester.
You're just doing normals.
Yes. Okay. But I'll go into them. Now she showed you how to interpret them.
We went over them a little bit.
Very quickly.
Oh no, this you're gonna have to know. Okay. We'll talk about because tomorrow I'm gonna show you how to do. She talked about the 6-second strip.
Yes.
Right? And how you read the 6-second strip and count the R's. Did you do that? No, okay, we'll talk We'll talk about that tomorrow.
We touched on it very, very briefly.
Okay, don't worry. You're gonna get an intense training tomorrow. So I talked about the different lung sounds. Oh, before I go into the different lung sounds, I also, because I don't want no problem.
No problem.
No problem. Know the different meanings on page 1593 when it comes to the cardiac functioning, the dysrhythmia. I know you already know it, but I don't want nobody give me no issue. What it means for dysrhythmia, ischemia, angina, or stable angina, and of course, MI and heart failure. Make sure you review those because it's going to come up, all right? So moving forward, because we got lots to do. Now, the test that or diagnostic assessments that they use with the MI? Yes. Okay.
You said 1593 or 1893?
No, 15.
Oh, there it is already.
Where was I? Yeah. 1593. The different meanings.
Sorry,
Okay.
it's very weird not having my physical book.
Yes.
Just real quick, the book defines dysrhythmia and arrhythmias as the same thing.
Yeah, they're used interchangeably. Yeah. Same enchilada. All right. Okay, moving forward, we did the EKG. So the different pulmonary function tests, as listed here. These are the different. Like it says here, at most, I'm just gonna ask you like questions. What diagnostics you expect to be ordered for pulmonary function tests, like based off of these? But do you need to know the values and all that stuff? No. All right, but just know of them. That's all I need you to know. Okay, because when you get into advanced care, then you're gonna go in more in depth as to how to interpret these results. Now, by the way, this is all talked about on that box on 40-1 on 1601. Just know what they are, that they exist, okay? On page 1601, the spirometry basically helps to evaluate the lung functioning. So patient will use what's called, I know it says in the book, the spirometer. Sometimes you'll have another word, or they also use the term incentive spirometer as well. All for the purpose of what? What's the point of having a patient use an incentive spirometer?
How much they can like exhale
They're meeting their goals.
and
Measure the
volume. Check their lung capacity.
Their title.
So wait, say it again, Mason.
How much they can like exhale.
Okay, that's one. What's another reason I would have a patient using an incentive
They
spirometer?
try to get a baseline before they go to surgery. So like after surgery, they can get back to their normal functioning.
Okay, that's actually good. Trinity? Oh, very good. That's also another reason to help prevent atelectasis, because like you said, Carlos, before surgery, you want to see their baseline, yes, and you want to teach them, and all your teachings, and we're going to talk about perioperative care, but all your teachings should be done pre-operatively. So you want to show them pre-operatively how to use an incentive spirometer, for example, so that post-op they already are aware and less anxious to use it, and you want to now see if they can meet their goals, because depending on certain medications, it can have an effect on their respiratory status. And one of the things you can use to help promote or prevent atelectasis and promote adequate lung perfusion is the use of the incentive spirometer, okay? Now, when you're encouraging a client to use the incentive spirometer, it is a RN, the registered nurse, who is eating, who is, in other words, teaching, because that's the T part of eat, is teaching the client how to use it. You are not delegating to anybody else how to use this machine. It's not a machine, this product, really, okay? That's number one. Usually the teacher will include, you want to do this 10 times every hour while awake. The more they use it, the better. If they can do more than 10, that's even, we're happy. But at least 10 times every hour while awake. We're not going to say it's bedtime and we still want you to use the incentive spirometer. Because remember, just like we learned, patient needs to rest as well, right? So the more they use it, the better. And you also want to try to encourage the patient to increase. Now, Mason, you did say it helps with exhale, but they also breathe in. You also want to see when they're breathing in how well their inhalation is as well. So it's not limited to just inhalation; it's also for exhalation too, depending on the client's need. All right. Again, you start off at maybe they're usually in increments of 50 or 100. Put it up, and then that little marker. Put it at a low level, see if the patient can either meet it or surpass it. If they surpass that previously, so now we have a new goal. Let's try to beat this. And you have to be, just like we've learned in our planning, we have to be smart, so we have to be realistic. The patient can't, just come out of surgery, for example, and you already want them to be at 1,000. No. Okay, that's not realistic. All right, so again, because you want to make sure you read carefully, start off at a realistic goal. If their baseline was 500, post-op, let's see how you are at 200. And if you meet that 200 mark or surpass it, let's go up, okay? Little by little, all right? Okay, optimal promoting, optimal functioning. Let me see, y'all already know how to use, before I get to this, y'all already know how to use the pulse ox. Don't play with me. When they are used, because let me back up a little bit. First of all, O2 saturation should be what again in terms of results? For the general healthy adult.
95 to 100.
Say it again?
95 to 100.
Very good. Again, remember some facilities will say 95 to 99 because some people will say 100 don't exist. It is what it is, okay? Now, however, we are paying attention to the client. The general healthy adult, 95 to 100. And if you below, like you at 90, you at 92, we're concerned. Which patient, if their O2 sat is like 89, we're not too much concerned?
COPD.
What's the normal O2 sat range for COPD according to your book?
88
to
92.
92 on page 1602, second paragraph, it is there. 88 to 92. For the purposes of this book, since we're using this book, we are going with this values. I just want you to know in other facilities or in other books, they have different parameters, but we're gonna go with this. Some will say 89 to 91 or something like that. I've seen before, I'm like, okay, whatever. So we're going with this results, okay? All right, what else? Now, let's say, give me a contraindication from you for using for assessing O2 sat with the pulse ox on a finger. What's some contraindications?
Yeah, okay, they have the polish.
Okay, nail polish, Mishka?
If you're taking the blood pressure at the same time and using the same finger.
Why?
Because you're already constricting the blood flow.
Oh. Great.
Sticker.
Oh yeah, that's sticker. Down. Okay, I don't know what a sticker thing is at.
Right in
Oh, I wear a lot of people's stickers with that regard. Okay, very good. Any other contraindication? Trinity?
If they have carbon monoxide poisoning, it's not going to give you an accurate reading of the oxygen.
Ooh, I did not think about that
2
one.
stickers.
Speak to me a little bit about that. Did you just? No. Tell me about that one. I did not think about that one. That's a good one.
Carbon monoxide stays to to hemoglobin better than oxygen, so it's gonna read that instead of O2.
Oh, so are you saying it's no point to even doing an O2 saturation on this client?
If they have carbon.
If they have carbon monoxide?
You can do it, but it's not gonna be right.
Okay, so how can I accurately, is it possible, number one, to accurately assess their O2 sat, and how?
I think it's the SaO2.
Okay, and how do you do that? Do you know? She's asking, I don't know.
Right to the artery.
Huh?
Right to the artery.
Stick 'em.
Find that good blood.
That good blood. What is it called?
ABG.
ABG, yes. Okay, that's a good one. Okay, so I can't test that. Let me try getting ready for med surge. Okay. Since you talked about that, Anton, you brought that up. You stabbing the patient. What is that called? This test that what you was doing. What was that?
Battery.
blood duke.
Huh?
No, that's not what I was.
He
that's
said
not
battery.
what I was doing. That's just that was my mind trying to come up with the answer.
Oh, okay. Oh, okay.
No, that's just getting the arterial blood for a better reading.
And then for
What's actually
ABG.
going through the system.
All right. Since y'all talked about ABG, which we're going to talk about more in depth in a little bit. Now, is there a test that you would do prior to? Is there an assessment that you would do prior to collecting the ABG?
Yes.
Capillary flow.
No.
There is, but give me a multiple choice real quick.
Is it the Allen test?
Oh,
You're trying
give
to.
me that. Okay, we're gonna work on that. Okay. Yes. Cause I will definitely test you on that. Allen's test. We're gonna go into it more deeply. Okay.
What page says that?
No,
Or
Allen's
not?
test is later on. I'm not even there yet. But since she brought it up, cause okay, you should be familiar with capnography, but I will not be testing you on that. But you should be familiar with it. All right. Also, with regards to thoracentesis, this I'm not gonna play with. What is a thoracentesis, Carlos?
Yeah, where are
Oh, page 1602.
Go.
Here, right here. Okay.
Oh, that's when they have a pneumothorax or not, whatever. They got blood, they got
Diffusion.
I thought it was
neural
plural fusion.
infusions where they have water build up in their lung.
Carlos Campela, stop, wait. What is thoracentesis? That's all I want to know.
Oh, when you drain the fluid out of the lung.
Out of the pleural.
Right.
Puncture the chest wall, insert a needle
How do you
into pleural
drain it?
space.
You puncture the chest wall and you insert
With
the
what?
needle.
A blunt needle?
No.
Okay. With
Turning
what?
a needle into the pleural space to aspirate pleural fluid, air, or both.
Yes.
They gotta leave for.
Okay. Now look at the procedure. Usually carried out with the patient sitting on the chair on page 1603 or at the edge of the bed with the legs supported. They also have, if they're unable to sit up, because that's the preferred method, they will have them lie down on the unaffected side. Okay? And they will use a local anesthetic is used just to help with comfort and pain to minimize those issues, right? The location where the needle is inserted depends on where the fluid is present, and once the spot is identified, the skin is cleansed with antimicrobial agent. This is basically how the procedure is done. Now, my question to you, Jackie, are you the one performing a thoracentesis? Yes or no?
Yes, right?
Yes, no. I would call the physician.
No, the physician or advanced practice professional.
It says it, does it not say it in the book? Tell them who's the one performing a thoracentesis?
Physician.
Yes, not a registered nurse. Don't play with me. It's done by the physician. You need to know your role. Stay in your lane. Make sure you pay attention. What is the responsibilities of the registered nurse as it relates to the thoracentesis? Collecting baseline data before, sometimes even during and after the procedure. During the procedure, observe their reaction. Monitor what their color is looking like, what their O2 stat is, communicating with them, helping them to stay calm, because number one, the most important thing is, it's a big old needle being inserted into this patient's body. That patient better stay still. Mm-hmm. Don't move, because any little movement basically could jack them up, okay? For lack of a better term. Okay, so you want to make sure, like, if there's any medications that's going to be prescribed, administer the prescribed medications, of course, as safely as possible, and the area has to maintain sterility. So this is something that is done at bedside. It could be done in OR too, but it's typically done at bedside. All right.
Usually it's an emergency situation, right?
Huh?
Would it usually be an emergency situation?
No, it don't have to be an emergency situation, but as long as it's been found that the patient has fluid buildup, so they can come in at bedside and do it right there. In other words, you don't have to have a code blue or rapid response.
Okay.
Okay? It hasn't been done during a code blue? Probably so. Okay? I have never experienced it, right? But listen, after the procedure, make sure you're assessing for complications. This is vital, very, very important. What are you doing? You need to know what you're doing before, during, and after this procedure. Right, this does require an informed consent. You are not educating the client about what's happening during this procedure, because you're not the one performing the procedure. The only thing is you're making sure that the patient is well educated on the procedure, that they know what's happening, that they were educated about the procedure by the physician or the person performing the procedure for the most part. And what you can tell them is, okay, this is what we're going to be doing as registered nurses. Before, we're going to be collecting your vital signs, we're going to be with you, we're going to stand by you to make sure you stay still, etc. Okay? But you are not educating specifically about what takes place during the thoracentesis. In other words, as the person doing it. All right, what else? Make sure even after the procedure, you monitor for complications, which includes pneumothorax, pain. Again, look at that, hypotension. And again, what is hypotension? What are the values of hypotension?
Less than 79.
Say it again, Sakina.
90 over 60.
90 over 60. You see how I was stressing vital signs? The range. Hypotension is what again?
Oh yeah, nice. Oh yeah, I got that written down.
Less than 90.
Say it again. Less than 90 over 60. That's what your book say. Less than 90 over 60. You have a blood pressure of 91 over 62. We tripping? You better not be. Also, because there's a puncture to the site, you are assessing the dressing. The physician will dress that area. You are assessing that area. Okay, very, very important. You're making sure there's no discharge or no leakage coming out from that dressing as well. All right, so that's the main thing. Monitor. Also, it says a chest X-ray is usually done after the procedure to make sure there are no serious complications. Usually, it's done after the procedure. All right, we cool on thoracentesis? Jackie, you ain't gonna trip? Okay, very good. We talked about thoracentesis, labs, numbers, Kenosha, numbers. We got ABGs. I'm going to stress ABG in a little bit because I know y'all are ABG experts right here. I know that. CBCs. These are some of the labs that we're going to be collecting. What is the labs?
1600.
CBC. What is CBC?
Complete blood count.
Thank you. Yes. Now, what data would you find in a CBC or a complete blood count?
For white blood cells.
White blood cells.
White blood cells.
Okay. Platelets. Very good. Very good. Okay. Very good. I know it's not mentioned here, but I still want you to know it. BMP. Put that somewhere in your notes. Because, yeah, I'm going to still test you on that. What is that?
Basic metabolic panel.
Basic metabolic panel. I know it's not in your book, but I still want you to know it. What's in the BMP, Chanel? Please school me.
Oh, I don't know that part. I just know what it stood for.
Oh.
Bruh, Chanel, I was not even so happy. You know, like, oh, shoot. You know? All right, Mason, how's Chanel out?
Creatinine.
Okay, you might get creatinine levels. What else? Huh?
Electrolytes.
And your electrolytes.
Protein.
Okay, yes, you might get that as well. You do need to know that. So you're going to see in your BMP, which is your basic. So you have your electrolytes. You're going to have like BUN and creatinine, for example, your protein levels as well. Because you're going to have your, for the most part, for now, electrolytes. Because we're going to talk about electrolytes more in depth. You better know what your normal electrolyte ranges are.
Where's Jennifer again?
What else to check glucose?
Blood metabolic.
You know what? I believe so.
Basic
metabolic
Says
panel.
glucose and calcium.
Yeah.
Basic
Oh.
Calcium? Yeah, calcium is an electrolyte.
Yeah, it's an
Like,
electrolyte. Come on,
calcium
basic.
under blood sugar. So.
Yes, basic metabolic profile. Panel.
Basic metabolic.
Panel. Okay, see that little table on 1600? Make sure you review it. Do not play with me.
Do we need to know cytologic study and cardiac biomarkers?
Yes.
You
Yep.
said what? The things that are in the table.
The cytologic study, because
cytologic study and
what is it? Because
cardiac biomarkers.
somebody talked about it, didn't even realize they talked about it, but it's there. This is why I want you to know. What is a cytologic study?
Oh, it's like a culture.
Okay. It's done to detect cells, whether it be malignant, infection, or blood sputum, whatever. Okay? Now, this, oh no, that's not what you should was talking about earlier. But notice when it comes to cytologic studies, when you're collecting the specimen, you want to, like the sputum culture, for example, like Janai was talking about earlier, the best time to collect the sputum culture is early in the morning after the patient has rested all night. That's the best time. And we want gunk, the nasty stuff. We don't want saliva. We want, you want them to go like deep into their skull, like, and spit into that container. Tell them we want go as deep as you can. All right? To give us that specimen. Usually, it involves 3 successive days of sputum collection, so back to back. In other words, now I'm not going to test you on the amount, but the book says that you need about a teaspoon, right? Like it says, deep breath, expel the air, and cough have that deep coughing. That's what we're looking for, all right? And then, of course, after the sputum has been collected, we seal it shut and send it down to lab, all right? Make sure you send it down with the patient's information, patient label, the date, the time it was collected, and you send it down using a biohazard bag. Because if you don't do all of that, lab will not accept it in most facilities. Lab will say, sputum not collected or specimen not collected if you don't appropriately label it, okay? All right, so that is that. What else? Moving forward, promoting optimal functioning. We want to make sure we teach them, because remember, you are an educator. You are always going to be teaching the patients how to make sure they maintain a nice, healthy lifestyle. You want to make sure you reduce anxiety. You want to make sure you maintain good nutrition. Now, let's stop on nutrition for a little bit. Micheska, with regards to nutrition and the respiratory cardiopulmonary system, what nutrition or encourage me to eat? Which include what?
Vegetables, fiber, protein, not a lot of carbs and fats.
Veggies. You said veggies, fruits. Okay, you know that kind of stuff. Because what nutrients? Low sodium, right? What nutrients, especially for the immune system, do we need again?
Antioxidants.
Okay, antioxidants. Yes. Zinc is good.
Protein,
Yes.
protein, albumin.
Which vitamins? With the immune system.
Complex
Vitamin 12, vitamin C, vitamin
B. Yeah, vitamin C.
Vitamin
That's
D.
what everybody know. Okay.
Vitamin D.
Okay. All right. Calcium, all that stuff. Okay. Now, of course, with regards to a healthy lifestyle and behavior, in addition to eating well, of course, you want to get them up and exercising. Vaccinations. Now, of course, you want to make sure you assess the patient's perspective as it relates to vaccinations, because everybody got different perspectives as it relates to vaccination. The most you can do is just educate on the benefits of being vaccinated. If they refuse, they refuse. Chest physiotherapy. Does anybody know about chest physiotherapy?
What is that?
I don't know. I ain't never heard of it in my life. Yeah, I ain't never PT, CPT.
Isn't that respiratory therapy?
Yes, but what is it?
It's like
Remove
help
the mucus.
that.
What is CPT? What is chest physiotherapy? You need to know this.
It's respiratory.
Chest exercises to help loosen up mucus.
How is it done? You are absolutely correct. Do you know how it's done?
Could you do some cardio?
Nope.
No?
That's not chest physiotherapy.
Isn't there like a vibrator, chest vibrator?
Okay, so
like
they
vest?
have a vest sometimes, if it's available, they'll have like a vest, and the vest is like vibrating, and that helps with the movement.
That's usually more for
fluid.
the patients with cystic fibrosis.
For example, because why?
Because it loosens the mucus. Yeah,
Okay.
I don't know how else to.
Especially for those who have lots of mucus. Now, if a vest is not readily available, is there another way that CPT can be done?
Yes.
Percussion.
Okay. Sometimes they'll specifically they'll say cupping. This.
Yeah, it's just
Cup your
vibration
hand,
therapy.
and then you do this. Because not every facility have a vest. And that patient has lots of mucus. We want to make sure we get rid of that mucus as much as possible, or get it moving. Because if it stays still, what can potentially happen again?
Harden.
Huh? I hear.
Oh, I was gonna say it could harden, and it could cause a blockage. I guess what Sakina was saying, pneumonia. Could be a risk.
Yes, infection and stuff like that. And then it could also lead to difficulty breathing, because again, that mucus is building up. Okay. Very good. Can we meet? No, not it says not can we. They're saying another thing we could do is meeting oxygen needs with medications. What meds can help with meeting oxygenation needs? I don't know what that is. Anything else?
Cough suppressants?
No, it's not just.
Expectorants?
Yes, there's also something else. What medications can help meet the needs of oxygenation?
Oxygen.
You can do steroids as well. They're doing, and also they do humidified air too as well. Yeah, that's just cough medicine.
Oh.
You should know, go to any Walgreens. You're gonna see cough medicine.
Yeah.
All right. Now, positioning. If we are trying to promote adequate oxygenation, what's the best position to have the client in? Say it louder. Thank you. Okay, do not play with me. What's another position besides high fowlers?
High phallus.
Huh?
And they lean forward more for like COPD.
Okay, you talking about a tripod position.
Yeah.
Okay, besides that, there's another one. Because I'm going to put it on the test.
Oh my God.
Oh my God. I'll give you a clue. They used to use it a lot, or encourage it a lot during COVID. That's the only clue I'm giving
Oh,
you.
the COVID, like, wrong, I don't know the name you put.
Oh, is that where you went to the fetal position?
Like a third.
Prone position.
Wrong, God.
Okay, like a turtle. Okay, I'll take it. All right. So if you're turning prone, that also actually helps as well. So now, in your book, with regards to the prone position on page 1607, prone positioning should not be used with patients who have facial fractures, unstable spinal or pelvic fractures, or increased intracranial pressure. So make sure you read that scenario very well. Don't play with me. Y'all know I love drama. Okay? If the patient have a facial fracture and respiratory distress, the nurse would intervene, or the charge nurse may intervene if they notice that the primary nurse puts the patient on prone position, for example. You understand? So make sure you read the scenario. But it's good for respiratory issues like ARDS and stuff like that, COVID, etc. Okay? Y'all been warned. Don't play with me. Alright. This you definitely have to know. You can't play with me on this one. Promoting proper breathing. Someone said it earlier. Encourage deep breathing exercises. One, you can encourage the use of incentive spirometer, which we already talked about. Pursed lip breathing. I do not know what that is. I've never heard of that. And every time I see pursed lips, it's like, do I put my lips to a purse?
No, just
No?
like act like you're blowing a kiss.
Act like you're blowing a kiss. Or also diaphragmatic breathing. Okay? Now, what else? Now, inhalers. You need to know. Yes, you do. Even though Nurse Sakina knows very well about the bronchodilators because it opened the lungs, you do need to know how to properly administer these inhalers. Okay? In your book, if I am not mistaken, like it says on page 1611, I want you to make sure you pay close attention to this. Okay? They tell you how to administer the medications, especially what the purpose of them, like bronchodilators, mucolytics, and stuff like that. Now, it could be, some of these medications could be inhaled, and some of them can also be taken orally as well. Like the mucolytics, for example. Mucomist is one. It's usually inhaled, but if you have that patient, if the patient has an order to take that thing orally, it's one of the nastiest things to smell. That's number one. So you are warned. All right? It smells like rotten egg. You put one of the best ways to get the patient to ingest it is give them juice with that medication so that they can inhale it, take it in orally, because it's pretty rough. Okay, to say the least. Okay, so some of what I'm saying, these medications, there's different formats in which they can consume the medications. Medications can be given via the nebulizers, MDI or metered-dose inhaler, or dry powder inhaler. Now, let's go to chapter 30. They talk about how to take those medications. 961. Because we're going to go, I don't want no problems. Because I could have tested you on it and I didn't. Oh, you saying?
You said 960?
961. Okay. Because y'all not going to give me no problems. Y'all know my exam's already cumulative. Look, on page 961 was what I was looking for. The MDIs. Make sure you pay attention to the steps. Let me say it again. Make sure you pay attention to the steps. Let's go. MDI, you going to first shake the inhaler. Okay? Remove the mouthpiece, of course, and then attach it. Have the patient place the and then use attach the MDI and insert it into the open end of the spacer. That spacer, you see what that patient is using on the bottom? That's the spacer, that little purple thing, that's the spacer. You want to make sure you attach it. The best thing, it is always encouraged to have the patient use a spacer, because if you use a spacer, instead of having them blow straight from the inhaler, it's not that they can't blow straight from the inhaler, they can do it, but using a spacer allows them to absorb the medication much better, and they get more benefits that way. But if you don't have a spacer, is it the end of the world? No, it's not going to be as well absorbed as if they had the spacer, okay? So have the patient breathe normally, and if they are using, whether they're using the spacer or not, the most important thing is to make sure the lips are sealed tightly, either around the spacer if they're using the spacer or tightly around the inhaler. Because if it's not, again, you will not absorb the medication as well as you need to, okay, as the client needs to, okay? So, like it says, have the patient place the spacer's mouthpiece into their mouth, grasping securely with the teeth and sealing the lips tight, and of course, breathe normally. And they tell you what to do if there's no spacer used. Have the patient breathe normally through the spacer and exhale completely. You see those words in red? Instruct the patient to hold their breath for 5 to 10 seconds. At least 5 seconds. Or as long as feasibly possible. Very important. Don't play with me. Then they can exhale slowly, utilizing the pursed lip method we just talked about. Wait 1 to 5 minutes as indicated before administering the next puff. It's not like, puff, puff, give, like we seen on next Friday. No. Take a first puff, lip sealed, hold it for as long as you can, exhale, wait 1 minute, okay, or 5 minutes. Because you want to give time for the medication to, I like to say, marinate in the body, okay? And then you take the next puff as ordered. Make sure y'all read that. You see? Don't play with me. And then, of course, after they have finished consuming the medication as ordered, then you want to make sure you have them gargle and rinse their mouth and the spacer as well. Clean it according to the manufacturer's direction. But they also have to rinse their mouth as well, okay? The DPI, or the dry powder inhaler, same thing. Breathe, okay? Remove the mouthpiece and load a dose if necessary. Some of these dry powder inhalers, y'all seen like some of the medication, they look like capsules and they have stuff in them, powder or whatever. Some of these medications or inhalers is just like that. They look just as if a pill. You need to tell the patient, do not swallow this, because you might get in trouble physiologically, okay? It looks like an actual capsule pill. What they're doing is, what you have to do is instruct the patient to open the spacer, insert the pill, and then close it shut. That close shut mechanism now will break open the pill. And then you follow the same directions like we just mentioned earlier, okay? What else? Same thing, wait 1 to 5 minutes between puffs. And then, of course, after consuming it, have the patient gargle and rinse with tap water, and then also clean the machine per the manufacturer's direction. You see, I took my time on this because I do not want no trouble, no problems on the test question. All right, oxygen. Let's go.
So was it just the meter dose and the dry powder inhaler?
Yeah. No. I'm going to test you on anything, but the reason I'm stressing the DPI and the MDI, I will test you on a small volume nebulizer and all the other stuff. Those are pretty much, self-explanatory. because students historically has been giving me problems, and I have to go back and refer to this right here. And they're like, oh, okay? So that's why I spent some time on this one. Oxygen, make sure you know the different sources of oxygen. And if I'm not mistaken, on page 1615, going back to chapter 40, you have to know this because, yes, I will test you on them. The different sources of oxygen goes from nasal cannula all the way up to venturi mask. Low flow are the nasal cannulas and the simple mask and the non-breather. Make sure you look at how much the liter is. For example, 1 to 2 liters will give about 24 to 28% of oxygen. Okay? Now, nasal cannula can go as high up as 15 liters. Let me say this again. Nasal cannula can go as high up as 15 liters. Once you start getting to 10 liters, that's considered high flow. Who will we not give more than, I don't know, 5, we won't give 5 liters of oxygen to? Why not, Mason?
Because they already have a bunch of like air trapped in their lungs, so adding more oxygen isn't that beneficial.
There you go. You see, Mason?
Wouldn't it also stop them from breathing?
You can. You harming them. That's exactly correct. Yeah. Okay. So now, I forget what your med-surg book says with regards to how much oxygen to give COPDers. Some sources say no more than 4 liters. Some sources I have read, but some sources say 5 liters. I'm saying no more than 4, because too much is not a good thing. Yes.
So in the rehab, we had a patient who was consistently on oxygen. When she got up to walk around, we had to titrate it lower. Will that always be the case?
Not always. Okay. That's patient specific. It's not always the case. Right. Okay. All right. So make sure you pay attention to the different sources of oxygen and what's the purpose of giving those oxygen and what are you monitoring. Nursing interventions are all listed right there. For example, venturi mask, high flow goes from 4 to 6 liters, requires careful monitoring of the FiO2, and you want to make sure that, check that air intake valves are not blocked. So those are the things you want to look at, for example. Pretty much self-explanatory. The other thing I want to address is making sure patient safety as it relates to somebody who is on oxygen. Number 1, you better not be smoking. It is an issue many times. Patient comes to the hospital, we have to tell them, no, you cannot smoke. You're on oxygen, you're going to blow us all up, okay? So no, don't smoke while you're on oxygen therapy. The other thing, NCLEX loves to test, I see this in a lot of NCLEX review books too, the material of clothing with regards to oxygen therapy. Is there a material clothing clients should not be wearing while they're on oxygen therapy? Huh? What'd you say?
Probably ones that are easily inflatable.
Okay, which one is it?
Yeah.
Is it polyester?
I thought it was polyester.
I think.
I'm not sure, don't quote me on that.
I'm not quoting you on that. I don't remember reading polyester.
It might not be. I thought polyester.
So is that synthetic? Is that considered synthetic clothing? Polyester?
Yeah.
Oh, okay. So then I guess if it's considered synthetic clothing, wool is another one too. Don't have that. You want to make sure with regards to oxygen safety, stay far away from heat sources.
Oils, grease,
yes, okay? Some patients, if they're using a portable oxygen tank, they have these long cords so they can easily trip if they're not careful. So you want to make sure you tell them, listen, we either going to get a shorter cord or we'll wrap it up this way so that you don't start falling, okay?
Hair dryers, wow, electric razors.
Say it again.
Electric razors, electric toothbrushes, hair dryers. Oh my God.
Oh yeah. Where are you reading at? So
16, 18.
16, 18. Y'all see it? Now, on 1618 in that little teach box, because yeah, I love it. Okay, the tubing length up to 98.42 feet may be used by patients. I have it highlighted, so that means I have a question on there. Okay, with flow rates of 5 liters per minute for home oxygen delivery. All right, I don't know why I have it highlighted, so I guess I have a question that I am removed. Okay, so again, make sure you pay attention to the oxygen safety methods. Make sure with regards to administering, you shouldn't use more than what is prescribed. Oxygen is considered a medication. Let me say this again. Oxygen is considered a medication. In the real world, when let's say you come into a patient's room and they show signs of respiratory distress, they're turning blue, we as nurses, we will automatically, autonomously, I should say, apply oxygen, but we won't give more than 2 liters, okay, in the real world. But you need to know that oxygen is considered a medication. You shouldn't be giving oxygen, because I'm teaching you as entry-level nurses, you should not be giving oxygen without a physician's order as entry-level nurses, because y'all know you got new kids on the block, y'all innocent for now, okay? What else that I wanted to make sure you know? No more than what the physician ordered. That's basically it. No safety brushes, like Cassandra was basically saying. No electrical toothbrushes, no electric razors, stay from electricity anyway, etc. You must know about chest tube. Let's talk about it. On page 1620. This is a surgical intervention that requires, of course, they can be done usually at the bedside, but usually it's done in OR after maybe some kind of procedure is done. And the purpose of a chest tube is for what? Anybody knows?
Removing pressure in the thoracic cavity.
Yes, okay. So now, when the patient does have a chest tube, on 1620, you'll see what that chest tube is. A long tubing that is connected to this device that's sitting on the floor. Our job, it is our responsibility as nurses to make sure we monitor the output. We are not emptying the contents of the tubing, but we want to make sure, number one, you see how there's 3 chambers? One chamber has to be completely filled, but before it goes into the next chamber. That helps to allow for adequate or accurate output monitoring. Okay, so let's say I'm giving handoff report to Janaya, and Janaya, we have a patient who has a chest tube. On my shift, I collected 100 total. It went from 0 to 100. So I am going to document a total output of 100. When Janaya shift is over, she had an output that went up to, if the number went up to 200, what is going to be Janaya's output? What is Janaya's output? When I
add your 100.
100.
You can't clear it.
And you can't clear it.
Yeah.
So that's why you always mark where you end. So I have to, Janaya, as the great nurse that she is, she's going to make sure I mark, as an ongoing shift, I mark where my output ended. It ended at 100, and today is 77, 1100. Okay? Then Janaya, hers stopped at 200. Her output is going to be, all you're doing is subtracting 200 from the 100. Her output is 100. If that's what she got. If it ended up at 200. If it ended at 150, what's her output? 50. Does that make sense? Okay? Okay, that's one thing with regards to the chest tube. The other thing with regards to the chest tube for safety purposes is that tubing, you have to make sure it is positioned in a way it doesn't get kinked to the side row, because it's very easy for that tubing to get caught in the side row. Okay? And you are educating everybody to make sure that they don't mess with that tubing. The dressing has to be an occlusive type dressing. I know we didn't do wound care yet, but the dressing, so you know, for testing purposes, has to be an occlusive dressing. Just like how you see on that patient in 1620, it's like that silk tape it's a lot of dress, they put gauze and then that thick silk tape over it because they're trying to minimize air going into that wound, okay?
Yeah.
But for chest tube, it don't matter what facility, what unit you're in, that dressing has to be an occlusive dressing. It has to be, because it has to add pressure, because the goal is, remember, the goal of the chest tube was to get fluid out. We don't want no air going in because then they could be at risk for stuff like air embolism. That dressing, you are always checking it periodically, not just once a shift. You may want to come back every hour. I don't know, depending, especially if it's fresh. Okay, because of the length of the tubing and the possibility of movement, it's supposed to be sutured in. Okay, by the surgeon who inserted and stuff like that. But anything can happen. Okay, so you're closely monitoring that site. You're closely monitoring the dressing as well. Okay, so that's the one. That's the main thing. What else? After the chest tube is inserted, you usually X-ray is performed. A chest X-ray is performed to make sure it's in the correct location, just to make sure we're doing the patient is getting adequate treatment as well. Okay. What else? So. There are different types of chest tube drainage systems, as discussed on page 1621, and they talk about the different types. So you have the water seal, which is also known as the wet suction chamber, and this is the one that has the 3 chambers where you have the collection chamber, a water seal chamber, and a wet suction chamber, like it says here. This one, like it says, notice a comment, it requires sterile fluid that's be instilled in the water seal and the suction chamber, and we're looking for pressure. Specifically, it has positive and negative pressure release valves and intermittent bubbling. This is what you're paying close attention to, the bubbling. All right? Intermittent bubbling indicates that the system is functioning properly. Let's say it again. When you see intermittent bubbling, that tells you that we okay. All right. Additional suction can be added by connection, like it says, to the system as it relates to the suction source. But we're looking for that intermittent bubbling for the traditional water seal chamber type chest drainage. Then you have the dry suction water seal. Again, 3 chambers, and those chambers are a collection chamber, water seal chamber, dry suction, and that could give up to 40 cubic centimeters of H2O. I'm not going to talk about how much that part, but I do need you to know the 3 chambers. Again, requiring that sterile fluid be instilled in the water seal chamber. You do not need to fill the suction chamber with fluid. In the dry suction water seal chest drainage, but suction pressure is set with a regulator. Just like the previous one, it does have positive and negative pressure release and has an indicator to signify that suction pressure is enough. Quieter, it is much quieter than the traditional water seal. So the one so far that we are looking for intermittent bubbling is the traditional water seal. If you see water, think bubbles, and looking for bubbles, we happy. Okay? The dry suction system, also the one-way valve, has a one-way mechanical valve that allows air to leave the chest and prevents it from coming back in. Notice, you do not need to fill the suction chamber, hence the dry chamber or the dry suction, and it can be set up very quickly during emergency situations. It works even if it's knocked over, okay, making it ideal for patients who are ambulatory. Okay, you see that? And it's not able to easily observe air leaks, monitor intrapleural pressures, or use as suction. So the one that we are suction, because I want you to read the scenario carefully. The one we're concerned about bubbling is which one again?
Intermittent. Or sorry, traditional.
Traditional water seal. You see water seal, we're looking for bubbles. Everything else that's dry is not required. You're not looking for water seal. Okay? That's the main one. And then a patient who is ambulatory, you would suggest which type of
Dry suction.
the dry suction, okay? So just pay attention to that for the most part. When you get to med surg, there's going to be more specifics on that. But for now, that's all I want you to know. Now, the artificial airway with the ET tubes, the main thing with regards to the ET tube, I want you to pay attention to the guidelines on how to care for those artificial airways. There's guidelines on 1622. I would encourage you to look at that. But also see, because I have seen this before, and I want you to make sure you know that this is an issue for the chest tube. Everything else, yes, make sure you read it, but do not milk the tube. Leave it alone. Do not perform milking of the tubing or squeezing the tubing, because that can create more problem. It is adding unnecessary pressure and it can cause more harm to the client. It is very important that you educate whoever is on the patient's case. CNAs or UAPs should not be touching the chest tube at all. Okay, they just gotta make sure it's stable, number one. Okay, but if you are a charge nurse, for example, and you see a registered nurse or another primary nurse milking the tubing, educate, no. You shouldn't be doing that, because that puts more pressure on the client and cause more harm. For the artificial airway, make sure you pay attention to table or guideline 40-4. First of all, are you the one inserting an ET tube? No. Okay, you're not inserting an ET tube or even a tracheostomy. That is done by an advanced practitioner, okay, or at least or the physician, okay, a surgeon, for example. All right, it's not within your scope of practice, but it's basically an artificial opening to basically help with oxygenation, to allow the patient to breathe better. On pages. Now, when it comes to taking care of it, some patients, when they have that ET tube, they have like these ties. Before you release the tie, the main thing is the ties. You have to insert the first tie first before you remove the old tie. Let me say this again. Many of the tubes, these ET tubes, they have ties. We'll call it necktie for lack of a better term, okay? If they have an old previous tie to hold the tubing in place, first insert the new tie after you perform care of the area. Put the new tie first before you remove the old tie. Because if you don't do that, you might be in trouble. The tubing might dislodge easily, causing more harm, for example, to the client, okay? Those things. You are assessing the site. Most of them have a dressing. You are also assessing the dressing, looking for drainage at the where the insertion was placed. Okay, if it is soiled, you are cleaning it up, because that is a high risk for infection. The fact that they even have this tube inserted to them, whether it be through the oral pharyngeal or whether it be through the endotrach or whether it be through the neck, for example, you are making sure you are assessing the site for any drainage, because if that drainage remains in place, we have other issues that we're going to be dealing with: pneumonia, MRSA, VAP. All right. Then of course, these are different nursing skills that you can do to help with respirations in the emergency situation. I do not test you on any of this, but except for CPR. Y'all need to know how to do CPR. All right. Now, remember when we said when it comes to prioritization of care, the main thing is airway, then breathing, then circulation. In that order. In other words, you're always assessing first your airway. If airway is fine, let me see how you're breathing. If breathing is fine, let's look at the circulation. There's only one situation that order changes. On page 1629, when we are dealing with CPR-related issue, your priority is no longer airway. Your priority is now circulation, then airway, then breathing. In CPR-related issue, cardiopulmonary related issues, you are driving the cab. C, circulation. A, airway, then breathing. In that order. So now I'm going to test you. I have a patient who, who's become unresponsive. And I can ask you, what should be the nurse's first action? And I could put, check oxygen. Everybody loves to check oxygen. Or I could put, assess airway. Because that's what we've been learning up until this point, is to assess the airway. But you gotta make sure you're gonna know, well, not make sure, but I will tell you, you're gonna get that answer wrong when the question says, start chest compression or check the pulse. Understand? So let's go over it on page 1629. Of course, you want to make sure everybody's safe. Like it says, you're checking for this responsiveness, and of course, just like how they show you in CPR class, help, are you okay? And, do all that, nice little stuff. And of course, you're going to activate emergency response, and then you're going to make sure you get an AED. Okay. In that order. Look for no breathing, like it says. If there's no breathing, now you're going to initiate CPR. We're going to start chest compression. Very important to start the chest compression. Start the chest compressions, and now here in your book, I know it's different in different settings or whatever, but we're going to go with what's in the book. Your book says to start chest compressions within 10 seconds, push hard and fast, giving at least 2 inches from as fast as 100 to 120 per minute. You're doing compressions. Some people just say, do as much as you can. I think the latest I heard, in one setting, they said just do as many as you can. So if the patient is responsive, are we checking compressions first? Hold on.
Unresponsive ABC. Unresponsive CAB, responsive ABC.
Is this? Are we in? Oh, we're in. Okay. Unresponsive client, our priority is?
Airway. Oh, you said responsive?
Circulation.
No, I thought you said responsive.
Yeah, I'm going to get y'all now. Unresponsive client. CAB. We driving the cab. Everybody else, what we doing? Airway breathing. We're singing our ABCs. Okay? Very good. All right. That's basically it for the most part. The rest of the book just show you how to do stuff. Okay? That we already talked about. All right. What time is it?
11:30.
All right, 11:30. Before I get a break. You know what? 5 minutes. I'm going to see, because I heard that was experts. I got 5-minute break.
Experts on what?
ABGs.
Oh yeah, we got that.
You do?
Hey,
Ben, hurry up.
I'll give you some intro.
10 minutes. Thank you.
I'm gonna get a piece of paper.
We're going to start with or without you.
Hey, you know what sounds fire today?
What we done?
Wingstop.
Oh,
And they just opened it right there too.
This one right here. It's not even on their website. I've been trying to look.
let's pull up.
Wingstop, bro.
Hey, everybody.
I'm going straight to that.
Still in pipes.
Dude, their flavor of the day is sweet heat chocolate.
Still in pipes.
Dude, their flavor of the day is sweet heat chocolate.
Okay. Huh? And then after we do that, we check airway, tilt the head back and the chin, like it says, and then we're going to address any breathing issues.